Well, hello, everybody, and welcome. I'm Erica Spicer Mason with Becker's Healthcare, and I want to thank you all so much for joining today's webinar, From Daily Engagement to Year-Round Gains, where we'll talk about turning data from remote patient monitoring and personal emergency response systems into quality wins. And before we get into the conversation, I'd like to walk us through just a few quick housekeeping items. First, if you have any questions for our speakers throughout today's session, please feel free to type those into the Q&A box that you see on your screen, and we'll be sure to follow up and get you an answer. Today's session is being recorded and it will be available after the event. And you can use the same link that you used to log into this session to access that recording. And finally, if at any time you have issues with audio or visuals, just try refreshing your browser, and you can also submit a technical question into that Q&A box. We are here to help. So with that, I am excited to welcome our wonderful panel of speakers today. I'm going to ask them to introduce themselves, share a little bit about their role, their background, really whatever you all think would be helpful for our audience members to know going into this conversation about quality today. And Dr. Kobernick, you're the first on my screen, so I'm going to have you kick
Oh,
us off with intros.
sure. Hi, Michael Kobernick here. I'm a senior medical director at Blue Cross of Michigan, and I have a career that spanned about 30 years in clinical practice in emergency medicine, as well as family medicine. I'm active in teaching population health at Jefferson College of Population Health, and have quite a passion for this subject. And then my roles at Blue Cross are primarily related to the commercial population, where I advise employers on strategies for managing healthcare benefits and can share some of their perspective on the areas we're going to be speaking about today.
Fantastic. Great to have you with us, Dr. Kobernick. Thank you.
Thank you.
Vanita, how about you next?
Hi, thank you. I'm Vanita Pendelia. I am also at Blue Cross Blue Shield of Michigan. I'm the vice president of the STARS program for not only Michigan, but for several other states through Emergent as well. I am a pharmacist by trade. I was in an integrated health system for 28 years prior to joining Blue Cross to oversee their STARS program, where I did do a lot of work in improving quality, not just in the ambulatory, but the hospital setting, in the health plan setting. So really bringing that knowledge into understanding the provider space, the pharmacy knowledge, the experience, into rolling it all up into STARS. So I'm excited to hear about the topic and share what we are doing there to improve STAR ratings.
Thanks so much, Vanita, and love to see the strong representation from Blue Cross Blue Shield of Michigan. Thanks for being with us. All right, Dr. Pitts, tell us about yourself next.
Hi, good morning. Thank you for having me. I really appreciate it. So my name is Richard Pitts. I'm a physician, background emergency medicine and preventive medicine. I've boarded in both and have an advanced degree in management. I'm here at Cal Optima Health. We're a managed Medicaid program. We do have a PACE program also. We have a big program. We're 877,000 people. It's a $4.6 billion operation. We have PACE, DSNP, the whole cornucopia of things. And it's great to be here. I'm the chief medical officer. I'm fortunate to have a deputy CMO as well, so I'm able to focus on the areas where we need focus. And one of the areas is, in fact, STARS. And STARS is key, and I love doing it. Love getting the message out that STARS, think of STARS as basketball, not golf. And what I mean by it's a team sport,
Mm.
not an individual sport. And as soon as people grasp that, you can really reach for the stars. No pun intended there. But thank you.
I'm loving the metaphors here. Thank you, Dr. Pitts. Great to have you with us. All right, and Tim, tell us about yourself next.
Hi, Tim Haas, medical guardian. I've spent the last 10 years developing solutions in the healthcare space, leveraging emerging technology and novel data sets to address use cases like medication adherence, patient engagement, um, decentralized clinical trials, engaging patients, leveraging digital apps, remote patient monitoring, and medical devices to allow them to participate remotely. At Medical Guardian, I'm the senior product manager for clinical solutions. I'm responsible for our remote patient monitoring, not only the devices, but what the experience is for members and caregivers and clinicians, and also working with our data science team to develop predictive models for key issues for seniors, including fall risk, cognitive decline, and social isolation. It's great to be here today.
Wonderful to have your perspective on the line. Thank you, Tim. And last but not least, Lisa, tell us about you.
Hello. Well, my name is Lisa Sipes, and I serve as the Senior Director of Member Experience at Medical Guardian. Um, Throughout my entire adult life, all of my working career, I have been in member experience and support facing roles. Specifically at Medical Guardian, I've been here for 8 years and again, been in multiple roles with member focus across operations, support, and experience. In my current role, I oversee our end to end experience strategy and ensure that every interaction from onboarding to ongoing monitoring is driving clarity and confidence for the members that we support. And one of my current teams also sits at the intersection of technology and human connection. We lead the live member outreach on behalf of the health plans that we work with. And we also actively train and test our AI models to ensure that the experience there is essentially the same as they would have with our human team. And I'm very excited to be here and participate and share perspectives today.
Thanks so much, Lisa. We're excited to have you as well. And what a great group that we have together today to talk about quality and member experience and the many ways that those two ideas intersect and how they relate to star ratings. So I really do want to start there and have our conversation kick off on a higher note of just getting a sense of what's going on in quality trends right now. I know that CMS star ratings are tightening. We're seeing bonus dollars getting harder to capture. So, from each of your vantage points, which quality domains, whether that's medication adherence, preventive screenings, or member experience, do you think are most at risk for plans right now? And what's driving that risk? I'd like to get us kicked off.
I'll
I
go.
can start us.
Yeah.
Dr.
Oh,
Condola,
I guess.
thank you. Go ahead.
No, nobody wants to.
Go.
I'll go first. So to pick up on the team metaphor, I think member experience, that means involving all the key stakeholders. So for the member experience, it means providing technology that's very easy to use. For the family, appreciating that they wear multiple hats. So they're a caregiver to the member, they're a parent to their children, spouse, and they have career commitments. So they're juggling a lot. So you want to provide a comprehensive overview of the patient, the member, without overwhelming them and equipping them with data that they can take to the doctor on when the member goes to visit. So, for example, rather than saying, I'm concerned about my mom's blood pressure, you can go in with daily capture of blood pressure for the last 6 months. And now you have data and you can say, this trend looks concerning to me. What do you think? For the clinicians that we partner with, we understand how the staffing shortages put a burden on them. And so we try to provide intuitive dashboards and next best action recommendations that really take some of the burden off their plate, but also allow them to focus on the most at-risk members. Mm. And then finally, for our payer and provider partners, it's looking at providing predictive models that really give them a chance to identify problems before they become too large and identify dissatisfaction drivers, which will directly impact quality measures.
Mm. Yeah, Tim, I appreciate how you're highlighting some of the other forces that are kind of at play behind the scenes in these quality domains. You're touching on staff burden and staff experience and supporting care teams in order to understand the problems that are in motion and to get ahead of them before they worsen.
Yes.
So really appreciate you highlighting that and the role that tech is playing. Dr. Pitts, I know you had your hand raised too, so would love to hear from you on this.
Sure. Teeing off of what Tim was talking about, I remember at Consumer Electronics Show, CES, probably 10 years ago, I was at a vendor and he was showing me how all this data can come in. It's wonderful. It can be dumped into the EMR. And the problem is, what do you do with it? You know, data rich, information poor. So I'm going to be kind of physician focused in a sense because the workload has increased enormously. And so if you don't have informed data coming in, it's really not going to be helpful. And so that ties into the team approach again, that the team extends beyond just the doctor's office. It's the various vendors that can assist us also. But I can tell you from the workload, I remember, not unlike Dr. Kobernick, I did some primary care because I love patient contact. And I was thinking about all the things I did, and then I was thinking adding on all of the documentation with respect to STARS. STARS is just about practicing good medicine, but now you have to document that you did the good medicine, all the data collection, and that can be a huge burden. So the team thing again, and you'll hear me say this over and over, is so critically important, whether it's the RPM coming in, but that RPM data has to be filtered. It has to be, okay, red, green, yellow. Hey, this person's red. You need to do something about it now. Green means, okay, nobody really needs to look at the green stuff. It's that yellow trending towards red. I get real passionate about this because, again, people sometimes think it's just data overload, burden to document everything, but it's really documenting what you're doing, good practice of medicine. It's all preventive and chronic care. It's wonderful stuff.
Thank you
If I
so
can
much.
add and build upon that, I think where I'm coming from, if I look at the star ratings and, where are the areas of concern that we're focusing, data rigor is absolutely important for that. But looking at the advance notice and what are the proposed changes over the next couple of years, I mean, HEDIS is going to be the predominant player for the influence on overall stars as most of the operation measures go away in the proposed, if that passes through to the point where, it's like 27% influence there. Then you have to really think about how are you performing on HEDIS with the Tukey model. So with the CMS cut point changes with the Tukey in the last 2 years, we've definitely seen a bigger impact on the HEDIS cut points increasing at a faster pace than even the year over year improvements. And even though they're high as it is, I think you then have to roll in where are you in your drug adherence metrics as CMS is looking at adding in the sociodemographic status. When that status gets added in, it actually could hurt many plans that don't have as many low income or disabled members because the hospital stay and the SNF stays are no longer part of that equation. So I think when we think about where are the areas that you have to focus on, I think you have to look at your own data to understand where are you having the biggest advantage. For me, I would say health outcome surveys really bubbling to the top because of how much of an influence it will have when the operations go away. And such a small number of members are actually receiving that survey, much smaller than even the CAP survey, which now means a larger population has to be impacted because now you have to assume a small percent of that is going to be giving 15% of your overall star rating. So I ramble through a lot of numbers to help you understand just how important the data rigor part is and digging into it. So when we look at where does a remote patient monitoring have a play and a role, it can impact multiple measures. But I think it's important for every plan to reevaluate which ones are the most important for you. Where are you lagging the most? And what's changing in the next 2 years to get ahead of that now?
Mm. Yeah, big data focus here in our discussion already. Dr. Pendolia, thank you. And Dr. Kobernick, I know you're coming from the same organization, but with a different focus area. So I'd love to know how your perspective compares.
Yes, and it's interesting. I was thinking about, okay, my background's mostly commercial and I advise employers. We have an expert here. I really want to call out of Anita here. She's an expert in this area and is seen that way across our organization. But here, the question I'm asking is, what can we learn from our STARS work, from our HEDIS work, from our approach to Medicare and Medicare Advantage that we carry over to commercial? And there's a tremendous amount of carryover there in whether it's care models that are focused on achieving quality benchmarks or care medication adherence, emergency services, reduction approaches, remote patient monitoring. It's really interesting because the proportion of individuals in commercial with multiple chronic conditions is going up every year. And so that where clinicians used to manage one or two conditions, they're managing patients in commercial with 8 or 10, similar to Medicare. Excuse me. So there's a lot of carryover between what we're learning in Medicare, particularly around the care models and the team-based approaches to the care models that carry over to commercial. And I'm very excited as that space develops to take some of the learnings to our employers with initiatives to improve the care of their employees.
Mm. It's great to know that you have that learning stance, Dr. Kobernick. That's great. Thank you for sharing. Before we move on, Lisa, wanted to check in with you to see if there's anything that you'd add from your end.
Yeah, I mean, I think it's interesting how expectations are changing so dramatically around communication and proactive outreach. And kind of to Dr. Pitts's point about data overload and having the data, there's one thing to have the data, and it's an entirely other thing to have the right approach to how you're actioning the data and what insights you're gathering and collecting and what you're doing with that. And so I think we're moving in a direction where that is one of our top priorities that we're working on, is understanding all of the challenges that the member base would experience and having the right actions to help them feel better supported and kind of turn those experiences around for the betterment of partnerships and member experience.
Mm. So well said. Thank you, Lisa. And I know that several of you already in your opening remarks have touched on this idea of remote patient monitoring and other tools that are very much data driven to help manage members' care. So I'd like to explore your use of those technologies for a bit. So whoever would like to weigh in would love to know how your organization is currently using RPM tools and personal emergency response systems to identify those at-risk members sooner and trigger timelier interventions, and would love to know what impact that has had so far on some quality scores like HEDIS measures or CAPS.
So I just want to make a quick comment about that.
Mhm.
In certain areas, RPM is so critically essential. And the reason is my experience with congestive heart failure. You're supposed to call it heart failure now. We were able to cut hospitalizations in half just by doing RPM. But there's a piece to that. And when you use RPM to identify people who are not doing well and are trending down, but there needs to be that personal intervention, where there's a conversation back. And so this is important to understand that if you can have the same person, or maybe now moving into the same AI, talking with that individual, what we learned is having multiple people call at the same time, it really just destroys that relationship. So RPM needs to be partnered up with a human or a human-like AI to really get the most out of it. But it was so dramatic that we were just dropped it. This was at a different location I'm at now, but it is incredibly effective in specific areas.
Yeah, 50% reduction is certainly something to note. So thank you, Dr. Pitts. Dr. Pindolia.
Sure, I can expand on that. We've also looked at remote monitoring in different disease states. We looked at CHF, so heart failure, hypertension, and COPD. We did do match cohort propensity testing because we do have lots of other programs in place, and just to understand what lift this would give. So with that, we did identify with heart failure that we did see a reduction in inpatients, but not as much with our blood pressure and COPD, at least not statistically significant for the match cohort. Independently, the numbers looked great. So I think that's a different call out that we have to make sure as everyone assesses these programs, make sure you're having an understanding of what your base programs are able to do, and is this building upon that. I totally agree with Dr. Pitts that you have to have an orchestrated member outreach, because a patient is not one disease, right? Or one star measure. It's across many, and there's so many competing factors trying to improve their own rate, so to speak, right? And so how do we get that orchestrated? I think AI is a great opportunity to leverage the different language tools to figure out how to do that orchestration in a single platform as well.
Thanks, Dr. Pindolia. And if you don't mind me asking a quick follow-up, when you talk about this orchestration that AI might be able to enable with the RPM tools, what would that look like at a high level? So is it, the technology, one care manager, someone at the hospital or health system. Maybe you could just give us a taste of that.
Yeah, I think I don't think it'll be the RPM tool that would be doing the member orchestration because there's so many other outreaches. It would have to happen at the health plan. The RPM is a feed into that, right? Along with other outreaches that are going on to then optimize what should be the message to that patient and the timing of it. I think that's the critical part, and it's been a challenging one. There are so many different letters and calls and texts and everything going on out to our members. Now we throw in the AI agents that are having discussions on top of that. And then we have the vendors that are doing that independently. Our members are getting overwhelmed when they have multiple disease states, right? So I don't think I'm looking at right now an RPM to be able to do that, but I think it is on that health plan to be able to do that.
Yeah.
Yeah, we partner with some of the vended solutions who are using RPM to assist manage patient conditions. Hypertension management is a good example. Diabetes management is another. And that information is actionable and actioned upon by the vendor. And I do think, to your point, that we will see them use AI to create the protocols for follow-up rather than using as much of the personal follow-up conversations. And the challenge that we have is not as many people take advantage of those solutions that offer the remote patient monitoring as will be assisted by that. But our hope is that more and more will.
I just want to add again to a little bit. When you have a patient and they have a chronic disease, it's a huge stress burden. They get diabetes, they got high blood pressure, they get failure, they can't lay down at night, they have to sit up. And these people are very stressed. And I saw this when you'd have the diabetic nurse call, and he or she would ask the same questions as the heart failure nurse, and then on to the blood pressure nurse, kidney failure nurse. People, and to Dr. Kobernick's point, people just hung up. They wouldn't talk to these people. If you have a single point of contact, you can really leverage things dramatically. And I do think that the potential for AI is there. I won't mention which one, but often I have conversations with AI. If it's a small language model, it works very well. If it's a large language model, sometimes you get those things called hallucinations. But we're running out of people to call people. And so we're going to have to figure out what we're going to do to maintain that touch. Maybe a little bit off topic, but it's very important, I think, for people listening to understand the burden of people receiving multiple calls, plus the burden of chronic disease. It's just flat out overwhelming sometimes.
Yeah, I appreciate you highlighting the burden on the members, not just you, Dr. Petz, but some of the other panelists too. It's a really important point to go into. But before we go further, Tim, I know you have your hand raised. Anything that you'd add? You have this great high level perspective, so I'd love to know more.
No, I just wanted to pick up on what they were saying. I agreed. With an omni-channel platform, sometimes the temptation is more, right? More messages across more channels more frequently. But really, the genius of a great AI-infused omni-channel is really understanding the individual and personalizing and tailoring the cadence, the messaging, the language in the messaging, and the channel. So less is more often to really do something meaningful. And then the other piece is how the member engages with the omni-channel, because what we see is sometimes the earliest signs that a member may be headed towards a decline aren't clinical. And as powerful as RPM is, often they're social. And you see reduced mobility or increased isolation or a drop in daily engagement, and they show up first. And that gives us that early signal to really engage with that member and try to make an impact. So when you're looking at continuous monitoring, yes, it's remote patient monitoring, but it's also smart safety devices and mobility monitoring and emergency alert patterns. All of that engagement over time really is a very powerful signal that can be proactive.
Absolutely. And Lisa, what would you add?
Well, I feel like Tim sort of said a lot of what I was intending to say, but I wanted to just add, related to the member abrasion pieces, it's really important to strike the right balance in the outreach strategy so that you're not overwhelm, we're talking about data overwhelm, but when we're talking about contact overwhelm and how that's going to impact, the member base. And generally it's, in addition to that, it's a hard to reach population. And so you have to really carefully curate how those interactions are going to go based on the data so that you can essentially handle as much as you can once you are able to contact them. And so that, presents its challenges, but I think that's one of the areas where AI really, really benefits the business because it sort of removes a lot of the busy work that essentially humans would have to do, and it saves the humans for, the actual interactions with the people that we're supporting. So
Yeah. Absolutely. And Lisa, just a quick follow-up. I know we've talked about member burden quite a bit already with some of these alerts or communications that can become very overwhelming. But with continuous monitoring and engagement tools, how can those real-time insights help with patient satisfaction or engagement? Do you have any examples of something that would fall in line with that?
well, I mean, generally with the predictive insights, I think it's really more about, as Tim was mentioning, tailoring the communications and making the people that we're supporting feel supported, right? And making them aware that, like, hey, we're not waiting for, a reactive moment where you've already had some sort of significant event. We're reaching out well in advance because we're looking out for you and we can see this in the data. And I think that goes a long way, in satisfaction overall, is just creating those experiences where they know and understand that we're proactively looking out for them and outreaching as needed.
Thank you so much, Lisa. And I wanted to take our conversation in a little bit of a different direction, but touching on something that came up earlier, and that was Dr. Pendolia touched on this concept of kind of orchestration of member care. And so I think collaboration is something important for us to touch on in this conversation. We know that quality initiatives are not siloed. It involves the health plans, hospitals and health systems, and even community care partners as well to make sure that members are getting what they need. So what does effective collaboration really look like when you're using remote patient monitoring and personal emergency response systems, especially when we're working to close gaps or prevent those avoidable hospitalizations?
I can start from, it's not just my experience here, but my experience in my former role. And it's also bringing in a caregiver. It's an important part of this conversation for many of our patients, for sure. But it's also the overload of the amount of data when we do have so much with the remote monitoring. On the one hand, it's great that we get so much data. On the other hand, it's overwhelming to consume and understand. So I think the key that we found is the caregivers are like, I have work, I have other things, like, tell me which one is the most important and what is actionable, and then what is the action I need to take. And I think when I think of our community partners, that's going to be the same take there. So I think a great example is the good old continuous glucose monitors. They've been around, but they've really taken off. The amount of blood sugar reads, it's really great for a member who understands that, and it's caused definitely an improvement in A1C control just by using that. However, the alerts of when they're really low and the action that needs to be taken to prevent the hypoglycemia or a DKA, right? That's going to be the key of where do we bring other people in to help and support the patients. So I still think when I'm evaluating remote patient monitoring, how are we going to use that data to bubble up the most important aspects and then have actual actionable steps that people can understand what to do. Sometimes it's not as easy, and we take it for that as a clinician, we understand it, so it should be pretty obvious to others too.
There's also Erica, you mentioned continuous patient monitoring. Not all RPM is continuous. So getting incremental data. So in the HF project that we were on, it was really about their weight in the morning was probably the single most important metric. And so the system was great because the patient just stepped on the scale and boom, it was gone. They had no interaction. But Touching on Dr. Pendolia, we're having this conversation, we forget about cognitive decline. As patients get older, who's going to do what with that data? Now, I've had some patients, man, they are all over their continuous glucose monitoring. But that's somebody who's really sharp. But as people get older, then it starts to get even more overwhelming. What do they do with it? And they panic. And who can they call? So we're not talking about this in a vacuum. So that's an important piece as you go through the decades. RPM is going to be more important in certain areas because it's who's watching out for these people. The other thing is, again, from a social standpoint, social economic standpoint, so many seniors are living alone now. And that's not going to go away anytime soon. And even in some of the board and care facilities, they're essentially alone. They're in their room. They get intermittent observation. So RPM has a huge role to play, I think, in keeping our seniors safe as well.
Yeah. Dr. Kobernick, I think you're weighing in, but you're on mute. Just wanted to let you know.
Yeah. Okay. Sorry about that.
No worries.
Yeah, the key point is really the care fragmentation that we're trying to deal with, that people with multiple chronic conditions have. They don't understand the services they need. They don't understand how to take their medications. And, they're on 10 to 12 medications, these folks. I always think it's about two medication per condition. They have no idea how to take their medications, and we have no idea. And when they live alone, how do we monitor the medications that are they taking the right ones? Just anecdotally, in my experience, I've seen many seniors taking twice the amount of medication because they weren't able to decipher how to take it. And these are significant problems that we can help address through remote patient monitoring that's really focused on the gaps we're trying to deal with. And so understanding where care is fragmented, how it impacts outcomes, and understanding all the social determinants of health that go with that. And because that's key. You got to understand that, as you say, people are living by themselves with multiple chronic conditions and nobody's checking on them. And so we have there is opportunity within the remote patient monitoring space to address these.
This is a pretty heavy conversation, so I just want to share one lighter story about RPM. We noticed one patient, and during the week, her blood pressure would be kind of not good; it'd be elevated. And then we also noticed a trend that she got closer to her doctor's appointment, her blood pressure improved. And then as soon as she finished with the doctor's appointment, it went high again. So I couldn't resist. So I said, "So what's going on with this pattern?" She said, "Well, I really don't like taking that medicine." Okay. But I also don't want to disappoint my doctor. So I always make sure for about 3 or 4 days before I go for my visit, I take my medicine and he thinks I'm doing really well. So another point for RPM is, as Dr. Kaepernick says, you really don't know what members are doing with their medicine. Right. So just threw that in.
Mm-hmm. No, that's a great story. That really does illustrate the point.
Yeah, absolutely. And I appreciate everything that all three of you have raised so far. We're talking about just the fact that caregivers need to be in the loop about what's being monitored and these numbers. And to Dr. Pendolia's point, for them, there's also this prioritization area where they need to know what's the most important or most pressing metric that's being read on some of these tools. And then Dr. Pitts and Dr. Kobernick, you're touching on some of these social factors too, like isolation and just the sheer volume of medications and treatment plans that patients are on. So it sounds like to your point, Dr. Kobernick, there are opportunities for RPM tools to address some of the more social, economic areas of care. Tim, Lisa, wanted to check in with you both if you have any responses to that, or if you have any compelling stories of a situation where RPM played a key role here. We'd love to hear it.
I'll go first, Lisa. So definitely agree with that we're trying to look at this more holistically. Earlier identification, and again, looking at social isolation and cognitive decline and picking up those signals and then integrating them in an appropriate way into the care workflows, into that dashboard, as Dr. Pitts was saying, sort of a red, yellow, green way to say, we're particularly concerned. We see some flags with this member and we think it deserves attention. And in some cases, being able to automate that. But those decline, cognitive decline, there are a lot of signals there. Again, from the omni-channel engagement, where you can do voice analytics and look at the pause between words, word selection, how quickly or slowly they respond, the tonality and the sentiment and what they say. There's a lot of rich data there, particularly when you're looking at it over time. You can just see a decline over months, that we escalate to the caregivers and say, there appears to be something going on here that needs intervention.
Right. And I would just add to that, there's a lot of advancement technology wise when it comes to equipment. And I'll speak specifically to PERS equipment and the ability to, passively collect data on certain indicators that are, indicative of a fall risk or potentially cognitive decline, that will allow us to, develop those targeted and timely outreach to try to, educate and coach and work with members and partners to close those gaps and prevent further escalation in their, their medical health.
Yeah. Lisa, thank you so much. And I know a lot of what we're talking about here, managing chronic conditions, many of those are closely tied to quality measures. And so just very brief background, I used to work at a health plan, and I know that quality initiatives can be rather short-term kind of bursts and efforts, depending on, which measure you're trying to reach, what outcome you're trying to see in a short amount of time. But I imagine that many of your organizations are aiming to have these quality improvements happen over the long term and for it to be a sustainable and ongoing initiative. So I'd love to know, beyond star ratings, how can organizations build those sustainable frameworks to keep quality improvement and member engagement strong throughout the year versus just a quick quality sprint or something of that nature?
I think that let me start this a little bit. I think by connecting to the caregiving community I think this is an area where we need a partnership. A health plan alone can't really create these opportunities, but I think part of the work is to create partnerships with our physician community, our health system community, to identify the problems that we're working on and come up with shared solutions. I don't think that we get each individually a health plan can hit those objectives.
Yeah. We're very active in that area for obvious reasons because we have oversight by the state of California Department of Healthcare Services. We have metrics they call MCAS measures. They're measured every single year, plus the stars. So we have various incentive programs for both our members and also for the delegate. We use a delegated model. So about 700,000 of our members are delegated out, and we meet with them on a monthly basis. To your point, Erica, how do you keep people engaged? And so we put up stars measures every single month with every single one of our members that are, I should say, our delegated units. And then on the patient side, we do have incentive. And what we've learned, there used to be a barrier of having to fill out a form. And it could be 6 months. So, immediate rewards are important. Most people like an immediate reward. So now we've moved to a flex card so that we can charge a flex card. So if they are seen, that money shows up in their card within 5 days. And it also saves costs because it's not, because the flex card, there's no human interaction. It's just they did what they need to do. They got their mammogram test, they got their colonoscopy, or they got their fit test, etc. They got the A1C done. There's small incremental dollars, but in our low income population, those small income dollars are significant. It may mean food for a week, if you can believe it. So it's a big deal. Incentive really seemed to help, although there's some indication. There was a paper in JAMA recently about a study about mammography in Singapore. And they found out, they looked at all the different incentives, and the number one thing that got more people in for their overdue mammogram was a simple postcard. Hard to believe, but it's out there in the literature. I was shocked when I read it, but that was a large study, peer-reviewed. It was interesting.
Yeah, fascinating. So incentives, community partnerships and collaborations. Dr. Pendolia, what would you add to this list?
Yeah, that last comment, Dr. Pitts, that you made, I was just going to say, I mean, I think the monetary incentives work for some members for certain areas, but an area that would be interesting, and I've looked into it and started delving in my prior job a little, and then looking further here, is how do you optimize the platforms that our members do go to? How do we make it where it's more engaging for them? Not to push out, hey, you're overdue for your mammogram, but what if we had actually in there, like in your local area, there's free coffee at your library. And when you're there, by the way, now they want to keep coming to your platform, right? Now you can start putting next best action steps right in there so that they're not bombarded, because from calling tens of thousands of members before where I ran the medication management program. I mean, members that have hypertension and blood pressure, like they are on numerous drugs and they've been told over and over that their numbers are bad. They should exercise. They should do this. It's kind of like a want for them, you know? So now how do we make that and turn it into something that they are saying? And part of that is how do you gamify some of the areas? So social isolation is huge as in our Medicare population. Then they would love that instead of maybe even just getting money, if there was things that if they could come back, and we tried this, we piloted before, is you look at seniors and we found some like plants and planting, some liked animals. And I forgot what the third, but those two are the main categories. And basically, every time they did an activity, they would get something. They could go take a walk and they would see with their dog and the flowers would start moving. They could get a treat, a virtual treat to give to their dog as soon as they did 3 activities. If they liked plants and gardening, they got to, get a free bean plant. I don't know, whatever. But that made it it helped with social isolation. They found a friend, they found an activity, and it really made them want to do some action steps that we would want. So I think if I think about where would we think of going with platforms or technology, I would say first, let's identify which platforms would we be wanting our members to go to, and then how do we make it more engaging so that they actually will want to come and see. And then you could give data about their actual, hey, by the way, we noticed your steps were down, kind of like the Fitbit, and they all do stuff like that. But how do we make it even broader?
Yeah. Dr. Pendoli hit the nail on the head because we haven't talked about culture yet. So culture is a big deal. So we have 8 or 9 threshold languages. Orange County, California, where I'm located, is a really a giant melting pot, but there's so many individual cultures. We just added Russian, if you can believe it, to our threshold language. We have a Russian population. We have Laotian, we have Cambodian. It's a very broad mix, but each one of those cultures have different expectations about healthcare. We have one culture that will not go for mammograms because if you look for cancer, you find it. Therefore, that's what caused it. I mean, there's just some really big challenges in getting people their cultural aspects. It'd be great. So I know we have some RPM experts. How do you address that in your RPM world?
Yeah. Yeah, Tim, Lisa, you're in the hot seat, but curious to know your perspective.
I could say companies like ours are definitely incorporating some of those things that we just discussed, gamification, multiple language support, but also under really looking at the social determinants of health and trying to have an appreciation at a very detailed level about what's going to resonate with the user. Because we all want the same thing, which is taking that data and shifting from a reactive episodic outreach to a proactive, meaningful engagement. And that meaningful engagement means we need to understand who they are and really do a personalized, tailored program for them. Because otherwise, no matter how good the program is behind that, if we fail to engage them, it's not going to matter. So totally agree with everything that was just said.
Yeah. Thank you, Tim. It's really interesting to hear how in sustainability of quality improvement initiatives, the role that technology is playing increasingly so. So I appreciate all of the ideas. This has been such a fantastic conversation. So I just want to thank the group for that. And I want to be mindful of time as well. So I'd love to get some closing and kind of forward-looking thoughts from the group. As you all look ahead, what do you think that leaders should prioritize right now to strengthen their star ratings for the year ahead? Even if there's just one actionable step that you think they could take to move in that direction, would love to know what that is.
I think the first thing is look at your own data to understand where you're lagging, and then look at where do you need to go in the next 2 years to get that change, looking at the advance notice. And I think it's going to be remiss if you don't look at how to use the data to drive that. You will fall behind if you're not doing this with a data rigor approach. And then the technology that has to get embedded, it takes time, right? So that's why the 1 to 2 year forward look.
Thanks, Dr. Pendolia.
I think what we see is sometimes as excited as we all are about the technology with AI and ML models and generative AI, sometimes it can be overwhelming, yet even to the enterprises. And so one thing that we found is start with a pilot, start with small, with proactive monitoring, identify a high risk population. We talked about social isolation, fall risk, recent hospitalization, a high risk population, keep it small, achieve some quick wins, and then pull back and say, how do we expand this? Where do we go from here? But if you get those quick wins in, then you're getting buy-in from all the right stakeholders. So that's a best practice that we strongly recommend.
I love how pragmatic that is. Thank you, Tim.
Yeah. Let me say that this morning I listened to an AI generated conversation between a senior citizen and the AI on how to use the blood pressure monitor. And it walked through the skepticism of the individual but taught him how to use it effectively. And I think that as we think about improvement, we have to really embrace the opportunities that AI offers to really scale some things.
Thanks, Dr. Kobernick.
Mm-hmm.
Dr. Pitts, what would you add?
So I'm a big systems guy. And I look at this, the whole issue around stars from a system standpoint. We have a tool now that could dramatically reduce the population of out of control diabetics. The result of that would be then all of this technology can really focus on the people that need to be focused on. And of course, I'm talking about GLP-1s. We have had, in our PACE program, we had about 50 people who are diabetic, and a substantial chunk of those people, we just were not able to get their A1Cs down. We put them on a GLP-1, and I think we have 2 patients left that are not below 9. So by doing that, then all of this technology can really focus on the people who need to be focused on. Continuous glucose monitoring starts to become, it's okay for the people who really need it. That decreases the burden of information, right? Because we talked about it before, and just you have a tsunami of information coming in, but it's data-rich information poor because it's just overwhelming what to do. So I'm excited about this conversation because it helps to focus the understanding of the importance of RPM. At the same time, we need to figure out a way to quickly decrease the pool of people who need it. So that may not be popular, but it's just, I've got probably a couple 100,000 diabetics, and they are a big challenge. So just leave it at that. And so, thank you very much for having me. I really appreciate it.
Yeah. Yes, and thank you. I think I learned more from you all than I brought, but thank you so much.
Oh, it's been a great.
Don't underestimate yourself.
That's right. That's right. I'd echo that. And Lisa, just want to check in with you too, if you have any final thoughts or a key action step for listeners.
Thank you. Yes. I think what we've seen great success in is operationalizing the proactive outreach step. So like Tim was saying, identifying a high risk group for fall risk or social isolation, and creating some targeted outreach pilot programs. We have seen consistent improvement, including 40% improvement in preventive screening compliance, with high satisfaction scores related to those pilot programs that we run. And so we found them to be extremely successful and have ultimately scaled almost every pilot that we have run when it comes to those predictive, proactive outreach program pilots that we've done. And so that would be that's my shining star.
Great.
No, it's fantastic, Lisa. And just to sum up for the audience members, these were some really great takeaways. So it sounds like, at a basic level, knowing your data and understanding where you're performing well and lagging, according to Dr. Pandolia, it sounds essential for organizations. Taking this kind of systems approach, as Dr. Pitts touched on, to leveraging technology to prioritize those highest risk groups. And then following up on that, Lisa mentioning after you've identified those highest risk members, how do you operationalize the proactive outreach? And then Dr. Kobernick and Tim both touched on the technology piece as well, about embracing AI and not feeling like you have to tackle everything at once, but starting small with quick wins and going from there. Just great advice and best practices for those listening in. Are there any final thoughts from the group before we close today?
No?
Just want to thank you for inviting me. I've learned a lot from the individuals here, and I think this is a really exciting time for our Medicare members, actually, believe it or not, that with all the technology and the advancements going on, then looking at different medications and how they're advancing, like there's a different way to get the gaps closed and really improve the care and the well-being of our members.
Yeah, thanks for that comment, because it reminded me that we really live in the age of magic medicine. The secret is, how do we get it out to everybody?
Right.
Mm-hmm.
Yeah, thank you both. That was well said.
Well, thank you all so much again. I can't tell you how much I appreciate the conversation, your candor, your ideas, and your camaraderie. There's some great camaraderie in this group. So I appreciate that so much, especially as a moderator. And I'm sure our audience has a lot to take away from this conversation. And of course, we'd also like to thank today's webinar sponsor, Medical Guardian. Thank you all so much. So for those audience members who've tuned in, we hope that you enjoyed this session, and we hope to see you at future Becker's webinars and live events sometime soon. Have a great day, everybody. Thank you again.
Thank you.
Thank you.
Thank you.
Thank you
Bye.
all.
Mhm.